Thank you, Chairperson, for that generous introduction. And I would like to thank Dr. Janaka Pushpakumara, President and the Council of the Anuradhapura Medical Association for this invitation. So, and also Ganaka for making my talk easier. So, actually, after all the clinical talks, this may look a bit theoretical, but to apply all you learned from morning, you need to have this patient-centered care, especially at primary care level. This is the overview of my presentation. So, if we consider the roles of primary care provider, patient-centered care, holistic care is one of the key. Actually, if we adopt patient-centered care, we can accomplish most of the roles in our care provision as well. If you look at the definition, patient-centered care is the care that is respectful of and responsive to individual patient perceptions, preferences, needs, and values, and that ensures patient values guide the clinical decisions. So, I have highlighted few words here where we are considering patients' preferences, needs, and we are trying to make a shared decision taking their views and opinions into consideration. Professor Barbara Starfield, one of the world-renowned primary care advocates, has said, I quote, "Primary care is person-focused care over time, not disease-oriented care. Healthcare should be organized around the needs of people rather than diseases," I unquote. So both these shows, especially at primary care, we have to look at the patient having the disease, not merely the disease the patient is having. Why should we adopt a different approach or a patient-centered care approach, especially in primary care? To primary care, I can see a lot of medical students and maybe medical officers in the audience. We get patients with undifferentiated illness most of the time, or very early stages of diseases. So our communication is very important to identify their problems. Also, they are coming from the community with their psychosocial issues. So getting to know the psychosocial problems, patients' ideas, concerns, expectations, exploring them, addressing them are very important. I'll come to all this later when we are discussing how to implement in our practice. And this is actually important at this juncture in our healthcare system also, because we know a lot of allegations, litigations are happening, mainly due to misunderstandings and lack of communication. So if you adopt a better communication or patient-centered approach with our patients, that will reduce these misunderstandings, complaints, and medical errors as well. Obviously, it's going to improve the outcomes due to better adherence and better management. Again, I'll discuss how we will be doing it later. So, higher patient satisfaction is very important thing for especially people who are providing private, I would say practicing as GPs, because your best advocacy would be the word of mouth of patients. Hari honda doctor කෙනෙක්. කතා කරන්න පුළුවන් doctor කෙනෙක්. So that is probably your advertisement. So that would come only from a satisfied patient. So to make your patient satisfied, patient-centered approach is the key. And again, in our country, we see a big issue of reconsultations. Why is it happening? If you ask from the patients, they are coming again and again because their problem is not solved. Again, primary care physicians would know quite a reasonable percentage, I would say maybe 15-20% of our patients come with physical symptoms due to underlying psychological social problems. Imagine a busy OPD. One doctor is maybe supposed to see 50 to 100 patients in a session. How can you explore this? What is the result? Now, they come with a symptom, you treat the symptom, but underlying problem is not sorted. So they come again and again, being a burden to us as well as to the healthcare system. And if we adopt a patient-centered approach, that will empower our patients, increase self-care, self-management. Again, if we look at our morbidity patterns anywhere, probably in the world, and especially in Sri Lanka, number one cause of consultation is respiratory problems. But just think to yourself, how many of these patients coming to get treatment for respiratory symptoms actually need treatment from a doctor? Most can be self-managed. But why are they coming? Because they are not empowered, they are not taught, they are not educated on self-care. So again, if we spend some time doing that, maybe later we will benefit by reducing the burden of patient numbers to our practices. If we have a patient-centered approach where we explore patients' problems, issues, then and also we'll be getting a better history, doing a very focused approach, and that will lead to reduction of unnecessary investigations, because we see sometimes patients coming with pure psychological social issues, coming with bundles and bundles of investigations. And then somebody, after some years, label them as somatizing. Actually, it's probably their problem is not being identified from the beginning. So, unnecessary tests, medications, referrals, admissions, all these can be reduced by giving a proper patient-centered approach. Again, now in Sri Lanka, unnecessary hospital admissions are not uncommon. Anybody going to a medical ward would know, post-casualty round, what percentage of patients have been discharged. Why? If they need care, they would be kept in the ward. They are being discharged because their problems are not identified and managed in primary care setting. And if we adopt a person-centered care, then better continuity and coordination also would happen. So that would integrate primary care with the next level of care, secondary care, as well as community care, which we cannot forget, because by definition, primary care is a community-based discipline. So we are responsible for our community. So we need to refer or coordinate care for the next level, that is secondary level, as well as back to the community. Then only we can involve the families, communities to improve their health outcomes. And by doing all this, we will be reducing the burden on the secondary tertiary care level. So in a nutshell, if we adopt person-centered care, that will empower our patients, that will incorporate sort of support systems, we care for their values, we develop respect towards them, and all in all, it will promote positive well-being of our patients and their families and communities as well. Why are we talking so much about patient-centered care at this moment in Sri Lanka? We all know we are facing a huge burden of chronic diseases. And with the aging population, Sri Lanka has the highest rate of aging population in the South Asia. With both putting together, we see a lot of geriatric patients with chronic diseases, as well as large numbers going into palliative care. So to care for all these categories, we have to, or we must use person-centered approach or tailor-made individualized approach, otherwise it will not be sustainable and it will not give the desired outcomes. Sri Lanka being a multicultural, multi-ethnic and a society with a lot of, big economic gradient, adopting a person-centered care where we are tailor-making care for individuals will minimize the care gaps. And as we discussed before also, this will reduce healthcare cost and out-of-pocket expenditure. Big problem, the trust of the population on the doctors. Now, if we again start practicing patient-centered care, we can rebuild the lost trust, because patients are going to believe in their doctors, not to suspect all the time. Most of the time, what happens is we don't communicate, so they don't know actually we are caring. We are probably doing our best or more than the best, but we have not communicated that, so they don't understand that. So rebuilding trust is very important at this time. And the country is going for a major primary care reform with a loan from the World Bank, grant from the WHO. So to do that, we are really advocating, or we are trying to train island-wide, we are trying to sort of start a training program for the medical officers on person-centered care, because without that, whatever do with the primary care reforms is going to fail. So to achieve universal health coverage and sustainable development goals, this is mandatory. Again, in the region, we have very good health parameters except for USA index. So to achieve this, we have to empower our doctors to provide person-centered care. So when we look at the person-centered care, there are different principles described in different literature coming from different places, but all go along the same line, giving emotional support, involvement of patient in decision making, involvement of families, communities, and continuity of care, giving physical comfort, educating patients, coordinating care between different levels of care, and respect to patients and for their beliefs and practices. So the most important thing, how are we going to do this? Right? So I will discuss all these in a very brief. This is probably a day's talk, but I'm trying to sort of give things in a nutshell, how you can do it at your practices. Building rapport. As Dr. Ganak said, start with a smile and talk to patients in a humane nature. They are not cases. They are patients, people. Preferably, if you can get their name, of course you can get their name, but if you can spend maybe few seconds to ask the name, use the name, that is very personal care. And sometimes our cultural background, most of the time doctors call people Amma and like that. But we did a study at OPD, Colombo South, where the younger generation mostly, but even most people preferred to be called by name. So probably the society is moving, so we have to also move with that. So try to address your patients using the name. That will indicate like we are personalizing the care. Avoiding jargon. Use simple terms to explain things. Summarizing is important for them to understand, as well as for us to clarify whether they have understood or whether we are understanding each other properly. Teach-back method is especially when it comes to sort of complex things like, inhaler use, maybe taking off medication regime. We need to make sure they understand properly. So, and also asking for clarifications at the end of the consultation is a good practice, because still our society, people are not really ready to question the doctors. They go back and question the relatives or known people without asking from their own doctor. So before ending the consultation, you can, as a habit, ask, do you want to ask anything else? Do you want any more clarification? So anything you want to sort of me to tell more, something like that would prompt them to just clarify their queries and they will be satisfied. And exploring agendas. Now, when we discuss about a consultation, we call doctor's agenda and a patient's agenda. We go with our agenda. Our agenda is to treat the patient, send the patient away, treat the symptoms. But they may have more than that. Sometimes they will come with a symptom, for example, woman coming with a back pain, just patient may be coming to discuss about the abuse happening at home. So they may have a different agenda. So try to understand that. Ask open questions and get the patient's ideas, concerns, expectations, and try to plan decisions or what to manage collaboratively, because there may be few things to address at a consultation. We can't do all within the limited time. But prioritization should be with them, not what we want, what they want. So we can it's a joint decision making, not only from our side. So shared decision making is exploring options, what is available, discussing risk benefit, and respecting their preferences. I will give you one good example. Now, we all talk about this lifestyle modification. When it comes to exercises, we say 30 minutes a day, 5 days a week, you have to exercise to be healthy. How many percentage of your patients must be doing that? We tell, how many times a day you preach this? But why aren't they doing it? Because that's not their option. That's not what is practical for them. So how to incorporate exercises into life has to be a joint venture where what they can do, get their option, what can you do? And then we guide them to use whatever they are selecting. And holistic approach, biopsychosocial model we call this. We mainly concentrate only the disease, that is the biological aspect. But we cannot forget the physical, social and the psychological aspect, because these are intermingled. We can't separate. Especially primary care, the patients are not very acutely ill. So, they may be having physical presentation, as I said before, also intermingled with these things. So unless we explore these things, we might not be able to identify the real problem. Also, when you're trying to manage patients, if you don't know their social background, the affordability, the support at home, a lot of things, even the level of education matters when we go to discuss with them, when we try to manage them. Listening and empathy, again, Ganika talked about it, as active listening to their problems properly, validating their feelings, exploring cause and effect of emotion. Because, don't think sadness is only the only emotion that we see. They may be angry, they may be in denial, they may be distressed. So identifying what has caused and how they are responding and how it's affecting them and being supportive is what we mean by empathy. So that is a very important thing we need to practice. Do we have challenges? Yes. Now also you may be thinking, right? How many patients we have to see? We do have time constraints. Overcrowded clinics. Communication barriers, because even if we have time, what to tell, how to communicate, it needs training. So training of care providers is one very important thing. We actually have to start from undergraduate level. Unfortunately, due to various reasons, we cannot really promote this, but maybe if we get together, this is something we have to focus on, and that's a plea from the Ministry of Health as well, especially with this primary care reform implementation. And reorganizing our clinic structure and involving and empowering patients. So how we can modify clinical process, ensure adequate consultation time. Actually, the Ministry of Health, we carried out a pilot project with 7-minute consultation, had some positive effect, but giving 7 minutes without training them on how to utilize that 7 minutes productively is of marginal value. So, and to do this, we need to actually empower patients, reduce unnecessary consultations, and we need to have more doctors. So again, with the reforms, we are planning to have maybe 7,500, 10,000 patients per doctor at primary care. That's a ratio we are planning, but we don't know whether we can achieve this. And use structured templates and the medical record system, so that we don't have to take every information at every consultation. We have background information so that we can utilize the time productively to explore their problems. Encourage continuity with the same doctor. Again, the plan is to have maybe empaneled population GNDs assigned to doctors, so that they will develop that my doctor relationship, the rapport, that will empower them to sort of share their information freely. And streamlining back referral system to empower the decision making and to facilitate patient care. Then EMRs, or at least paper-based, our famous exercise book even would do, to provide continuing care, because then that will save a lot of time taking background details every consultation. And enabling referral tracking, follow-ups and shared notes between different care levels, again, that will save time at both ends if we utilize proper documentation. Engaging patients and communities. This is another new concept, engaging and empowering communities. So by doing this, by educating our people, especially on self-management, will reduce our burden of care. Because if we educate our people to have a healthy lifestyle, the NCD occurrence may be delayed or prevented. So care burden to the doctors would be reduced. Similarly, I said before also about respiratory symptom management. So if we have proper education system for our patients, then that will reduce the care burden to the healthcare system. Encourage to visit local institutions, because we see a lot of bypassing happening. So with that, again with the reforms, we are trying to have formal care delivery at all the primary care institutions, so that patients would be encouraged to visit the nearest institution, which will reduce the out-of-pocket expenditure as well as accessibility to care as well. Being cultural sensitive, being gender responsive, and addressing language barriers, utilizing simple terms. So all these things will help in addressing equity and utilizing the care packages, which we are planning to do again. So that is what will sort of streamline the care. Wherever you go, the care packages would be same or similar, so that people would get equal care wherever they go. And even the care packages, we have to use in a patient-centered manner, tailor-made to individuals. Care packages will be a guide, but we have to utilize it in a sensitive and a tailor-made manner to suit our patient in front of us. By doing all this, we can have better adherence and reduce complaints, so people will be happy about the care provision, because they understand what we are telling, they understand the care, they understand their problems, they understand the follow-up plans. So that will make them sort of adhere to the care plans as well as their satisfaction. And altogether, these things will improve outcomes to our patients. The cumulative outcome will be healthy communities, healthy patients. More than everything, high doctor satisfaction. We will be satisfied for doing a better care. I end my talk with a quote from Sir William Osler, the father of modern medicine. I quote, "The good physician treats the disease. The great physician treats the patient who has the disease." I unquote. Be happy by treating the patients, not only the diseases. Thank you.